Hi everyone, this is Felice Darko. I'm a pediatric neuroradiologist in London at Great Ormond Street Hospital for Children and Evelina Children Hospital. And I'm very excited to be part of this amazing virtual course. And thank you very much for the organizer of the Hot Topic Virtual Edition 2021 for inviting me. While I share my screen, this lecture will be um, about pituitary and pineal region tumors in children. And what I really would like to do is for you guys to provide a guide for the differential diagnosis. I will give you some pearls and I will show you some pitfalls that really reflects what I do in the everyday practice. And as you can see here, I'm on Twitter, and most of my lectures, if you are interested, are on YouTube. So you just write my name on YouTube, and there is my channel, and on SlideShare, because I'm really doing a lot of experience at Great Ormond Street and at Evelina, thanks to my amazing colleagues, and I really would like. I really want to share this experience, these amazing cases that I learn a lot from. So let's start with the warmer case. This is a big tumor, as you can see. And the first things that I do when I approach mass in the brain is to think of the location and the signal characteristic or the CT characteristic. This is very helpful, and we worked a lot with my colleagues in trying to understand what are the important elements for differential diagnosis, and also to debunk some myth about differential diagnosis elements that are not really helpful. In this case, what are the imaging characteristics? Have a look for a few seconds. First of all, location is in the basal ganglia. On the right, it's quite big mass, is heterogeneous with cystic and solid areas. So there are calcification. There is enhancement here, as you can see in this spin echo, and diffusion restriction. You see that on DWI, the intensity is slightly higher than the cortex that is already a packed structure, so full of cells. So this means diffusion restriction, so high cellularity, and there are internal calcification. So what is that? It's very difficult to do this diagnosis. When we reported this case, we gave a couple of differential, but the important thing is that this was a basal ganglia germinoma, and I show you this case to show you, first of all, one of the uncommon but quite typical location, characteristic location of the germinoma in the basal ganglia, and the fact that most of the germinoma do not have this kind of mass effect when they appear in the basal ganglia, but in this case, the appearances were slightly different than expected, and this is why we put also an aggressive glioma in the differential. Would be unusual to have an ependymoma in the basal ganglia. They are more in the periventricular white matter, but they can show a restriction and quite aggressive feature with necrosis like the ependymoma rera positive, for instance. So keep in mind this differential in terms of large supratentorial masses in children. What is the typical appearance of the basal ganglia germinoma? This is the typical appearance, something fairly non-specific. You see, this is from a beautiful paper in neuroradiology by the group of Gaslini, Giovanni Morana, Cesar Alves, Andrea Rossi, and so on. And they show these areas of abnormal signal in the basal ganglia on the left with this really subtle, fairly non-specific focus of abnormal signal in the globus pallidus on the other side, confirmed in FLAIR. Now, the important thing is that first I show you that because most of the time you have this fairly non-specific signal that is the first radiological appearance of a germinoma that is in the basal ganglia, and also to show you that over time the basal ganglia can slowly going toward atrophy, but also the importance of SWI. These children have with basal ganglia germ cell tumors that are mostly, but not always, germinoma. We'll come to that in a moment. They have susceptibility. So the first pearl, so the second pearl, first pearl is remember the possibility of a germinoma in the basal ganglia. Second pearl, use SWI, not only for the diagnosis. You see on the other side, this iron accumulation is much more evident than the abnormal T2 signal, but also in the follow-up after therapy, you can use, and again, I will show you another example from the same paper, SWI for the follow-up. So that's the second thing important to remember. Of course, the typical appearance of a germinoma is this: you have a mass either in the suprasellar region or in the pineal region, or in both, like in this case, these two areas. So you have this different location. The germ cell tumors can be heterogeneous. Again, Giovanni and colleagues, so Dr. Morana and colleagues, they use SWI and they try to differentiate between germ cell tumors, so different kind of germ cell tumors, germinoma, versus non-germinomatous germ cell tumors using SWI. And despite both of them can have a calcification, the iron content beyond the calcification is more typical from non-germinatous germ cell tumor. So that's another important use of SWI. But remember, the typical appearance, the typical location of the germinoma can be either pineal region or the suprasellar region, or both, as in this case. So another important thing to remember for not only for the germ cell tumors, is that the absence of the posterior bright spot when you see either a mass, like in this case, or a thickening of the stalk or of the infundibulum, is an important sign of pathology. Although when it's present alone without other symptoms, without diabetes insipidus, can be just an incidental finding. So remember that you have this other thing to look at. Very, very important, although non specific. This is the paper I was speaking about from Gaslini's hospital in Genoa, north of Italy. And the first thing that they show is that there is more heterogeneity in these non-germinomatous germ cell tumors, like in these cases, and they often have susceptibility in SWI that is in keeping with blood. So they have hemorrhagic products inside that are fairly typical for NGGCTs, while not found in germinoma, apart from the calcium that can be present. And you can see also the heterogeneity, although if you read out all the literature, the heterogeneity is a bit more, is useful, but only to some extent, because you can have an overlap if you look just at the internal structure of the tumor. And again, look at the different location, can be bifocal, like in this case, or mainly in the sellar suprasellar region, or only in the pineal region. So this is a good slide that I want to show from this paper, because really shows all the possible combination and the differences in SWI. So remember, the use of SWI is not well known, but this publication showed in this pilot study how important it is. Again, for the differential diagnosis, which can be difficult, but remember that you have also the lab, so alpha fetoprotein and BHCG. So gonadotropin, human gonadotropin can help you because they are typical of non-germinomatous germ cell tumors. Another important thing, as I told you already, is the use of SWI in following up these tumors. So in this case, you have one patient with disseminated germinoma, when this area of metastatic disease correspond to abnormalities in SWI. And then follow up after radiotherapy, you see that this area is gone, so tumor response to therapy, but the SWI changes are still present. There are new areas here. Again, 4 months afterwards, you have this negative post-contrast scan, but SWI showed progression that then only 8 months afterwards show some also corresponding enhancement. So they speculate that SWI can be also useful as monitoring in these cases, in these tumors. Another case, so we have seen all the spectrum of germ cell tumors, some differences, and the importance of SWI. Now, look at this other case. Pineal supravermian location, so the pineal gland is involved. There is this fluid level, this is blood, striking diffusion restriction, not enhancement whatsoever. There is a bit of hyperdensity, can be blood, can be calcium, but what are the main differences from the previous one? There is hydrocephalus. Well, the location is slightly different. So this is more supravermian, but actually you can have this entity also center on the pineal gland. The another very important difference is the lack of enhancement and the striking diffusion restriction. All the rest doesn't really matter much. You can have blood, which shows some density in CT, associated hydrocephalus. Another important thing, remember, few years are not very important in adult neuro-oncology, but in pediatrics, they make the difference. If you say something restricting, even not enhancing, especially if they do not enhance, actually can be a clue, in a very young child, think embryonal tumor. Embryonal tumor can be different, of course, in this location. You may think pinealoblastoma, but in the supravermian location, so not typical pineal location, think ATRT. So this was an ATRT, and again, I repeat the characteristics: CT hyperdensity, this was blood, hydrocephalus, restriction, and no enhancement. Remember that embryonal tumor, ATRT, sometimes medulloblastoma, like especially the group 4, and almost all the ATMR have no or minimal enhancement. So that's my diagnostic pearl for this case, but you can see how similar can look to other tumors in this location, like pinealoblastoma or even germinoma. But the pearl is look at the age, because a germinoma will never happen, to the best of my knowledge, in such a young child. So this was an ATRT. Just to tell you, the ATRT can be everywhere in the brain. They are heterogeneous unless you pick them up quite early, and they show diffusion restriction. But remember that as for the medulloblastoma, you will have other lecture about embryonal tumor in this hot topic virtual edition. But remember that there are molecular subgroups of ATRT as well, and you have the ATRT can be everywhere, but in particular, the tyrosine activate ATRT can be in the posterior fossa and shows a lot of the time peripheral cyst. So I show you an ATRT before involving the pineal and supravermial region, but here you can see a typical location in the posterior fossa with striking restriction. You don't care about the enhancement, but peripheral cyst, you have very good chance if you write in your report to get it right if you write ATRT tyrosine activated, because posterior fossa restriction, young child, peripheral cyst. This is just slightly off topic in terms of pineal and suprasellar and sellar tumor, but I think it's important for you to connect the dots and not consider the ATRT only in that location I show you before. Another important thing regarding embryonal tumor is that they all show diffusion restriction, but again, look at the age. I show you how important is the age to differentiate germinoma from embryonal tumor in pineal region, but also in the posterior fossa. These are very similar looking apart from the cyst here, but completely different in terms of age and also in prognosis. This is actually an ATRT, very young patient, less than 3 years, younger than 3 years, very bad prognosis. 8-year-old, this is wingless medulloblastoma, very good prognosis. So every time, no matter which kind of tumor you are looking at, which kind of location in the brain, remember to look at the age of the patient. Coming back to our location in the pineal and sellar suprasellar region, look at this tumor. You have this bright, hyperintense sellar tumor here with hydrocephalus. Remember, look at the inferior bulging and anterior bulging of the third ventricle for obstructive hydrocephalus. And there is also a lesion here. This is a post-contrast scan. You can see some area enhancing, some areas not. Um, you can take a moment to look at this scan, but it's very important that you know this enhancement, but also that there is something wrong on the clava. Something is enhancing also at that level. So this is something in different location. It's not the typical bifocal germinoma. This is metastatic tumor. What do you need this to distinguish from the other? Well, enhancement can help, but enhancement, remember, can have a lot of problem related to the technique. So when you acquire and which kind of technique you acquire, if it's a gradient echo, MPDH, a spin echo, a space, MT, and so on and so on. But when it comes to pediatric tumor, trust the diffusion first. So this is not a bifocal germinoma because there is something else, but it's not even a bifocal germinoma with a metastatic disease on the clava because the ADC map show very high ADC values. So this is a non-restricting tumor. I show you that germinoma tend to have restrictions. So this is a pilocytic astrocytoma, a metastatic pilocytic astrocytoma. Remember, pilocytic astro can metastatize in 10% of the cases unless they are in the posterior fossa. Another case, another young child. So I told you already, this is unlikely to be a germinoma, but the location is in the pineal region. Again, hydrocephalus, and again, diffusion restriction and low T2 um, um, signal that together with the diffusion restriction implies high cellularity. There are calcification. This is not the same patients I took from literature because I didn't have the CT in this patient. But remember, high cellularity, look at T2, look at DWI. There is a contrast for sure, and there is hydrocephalus. This three situation, this the combination of three finding plus calcification in a very young child are again suggestion of an embryonal tumor given the location we will call pinealoblastoma. Remember, pinealoblastoma always is associated with hydrocephalus, while germinoma depends. This is another case of pinealoblastoma, just to show you that they can be quite aggressive, quite big, heterogeneous. And look at the calcification. They are at the center and at the periphery. And look at the post-contrast of the spine and of the brain, metastatic leptomeningeal disease. So this is a pinealoblastoma with metastasis. Remember, you need to image all the neuroaxis, and also remember that the new classification of tumor, the one in 2016, and there is another one coming now, do not include the term PNET anymore. This is an embryonal tumor, given the location, most likely a metastatic pinealoblastoma. Again, very young patient. So what are the main differential diagnoses between pinealoblastoma and germ cell tumor? First of all, younger patients in pinealoblastoma and in general in embryonal tumor. Hydrocephalus is more frequent in pinealoblastoma. And if you see bifocal and or basal ganglia, think germ cell tumor. You have CSF and serial marker like alpha fetoprotein and gonadotropin that are more for NGGCT. And also, remember that sometimes, given the fact that both restrict, it's very important, very difficult, sometimes impossible to differentiate the two entities. But to be fair, radiologically, but to be fair, we are clinical radiologists. So we need to check the labs and we need to check the age of the patient. Then you read the books, and also in some, we wrote a chapter with Professor Sotiros Bisdas, the chapter for on brain tumor on for the ESNR book. a couple of years ago. And I also wrote this, is reported in every book, that engulf calcification, so at the center, are for germ cell tumor, peripheral for pinealoblastoma, but actually you have the opposite here. This is a case from Gosh, this is a case from literature, and in this other case from Great Ormond Street, you can see, as I showed you before, that peripheral and internal calcification. So I do not use anymore the calcification to differentiate these two entities. Another important thing about the how important is to connect the dots in pediatric neuroradiology. This is a child with a large right orbital mass. What are the characteristics of this mass? You have diffusion restriction, so aggressive mass, quasi-invasive, and with nodal metastasis. This is about the pineal and a sellar region tumor, so there is something going on in the brain for sure. We look at the brain and we have an embryonal looking tumor. Why is embryonal? No, a very young patient, no enhancement, striking diffusion restriction. Trust the restriction first, the diffusion first in the differential diagnosis. And what is your diagnosis? Among aggressive tumor, metastatic neuroblastoma possibility. Um, However, metastatic neuroblastoma is very rarely involving the nodes, but possible, and it is very, very rarely involving the brain parenchyma. Normally, we would expect metastasis in the skull. And then you have rhabdomyosarcoma, or SMARCB1 mutation, or atypical tuberculosis in immunodeficiency. The answer is this is a SMARCB1 mutation, and just to show you, the ATLT and pinealoblastoma carries this mutation that is associated with synchronous rhabdoid tumors in the head and neck region. So keep looking, match together the dots. That's very, very important. And I will show you some example in the differential diagnosis. Another important thing, this is a tweet I put a few days ago, because we received another scan where we are following up this patient with a cyst in the pineal region. There are a lot of studies demonstrating that there is no reason to follow up this cystic lesion in the pineal region unless you have striking solid portion, even if sometimes, like in these cases that is from the book chapter I told you before, you can have hemorrhagic changes that of course enlarge the pineal gland in comparison to the normal cyst of the pineal gland. In these cases, if you don't see any enhancing nodule, probably this is just an hemorrhage, and your problem is just to cure the mass effect. Actually, neurosurgeon problems is to cure the mass effect rather than looking for a tumor. So remember, this is very rare anyway. This is another case with a large mass, again restricting, again with a lot of susceptibility, calcium or blood, and T2 hypointense. So this is probably an aggressive tumor, probably an embryonal tumor. But remember, again, connecting the dots is very important. Keep looking. This child had lesion in the eyes, showing calcification, showing diffusion restriction. This is a parasagittal fat SAT that we use in this case, post-contest, of course, showing very well the nodules, no involvement of the nerves. This is trilateral retinoblastoma. So this is a typical location or intracranial location of retinoblastoma. So don't forget trilateral retinoblastoma as an embryonal mass in the pineal region. So my top tips for differential diagnosis in pineal region masses, and of course we touched also on the suprasellar. Use age for differentiated pineoblastoma or in general embryonal tumor and germ cell tumor. Use diffusion to differentiate pilocytic, astro, and low-grade gliomas in general from hypercellular tumors. Image the wall neuraxis. Use SWI, use CIS, so high resolution, or CIS or drive, depending what scan do you have. So high resolution steady state T2 weighted sequences, and look for multifocal location that can give you a clue for the diagnosis, like in case of trilateral retinoblastoma, SMARC mutation, or bifocal germ cell tumor. Look at this case. There is a nodule here in the infundibulum, in the anterior part of the third ventricle. but nothing else really. Something here we were not sure about, but look how the cyst depict this extensive metastasis everywhere along the fourth ventricle, and then the sylvius, and in the third ventricle with this epidural collection, probably secondary to the involvement of the spread along the meninges. So this was a good example of a metastatic low-grade glioma that shows how the cyst is very powerful sometimes over the contrast 3DT1, because sometimes this the enhancement is minimal or absent or variable. So this is very useful for midline use every time. Another case that's very interesting case, this time is another mass in the pineal region, but is hypodense. There are calcification, but there are also this area that are quite hypodense to the mass and to the fluid. So there is something different going on. And the mass enhances, but look at the T1. So this is T1 pre, this is fat. This is a form of non-germinative, sorry, I cannot say germinatus germ cell tumor, and this is a teratoma, and shows just the usefulness of T1 pre. So very, very important to use all the sequences depending on the case. Another important case, 3-year-old female. This case involves only the suprasellar region. And again, think of the characteristic signal and morphological characteristic of the mass. This mass has calcification, shows this T1 quite dense signal because of proteinaceous content, sometimes bleeding. There is a remanence in contrast with some nodular areas and some solid nodules as well. This combination in suprasellar location are typical of a craniopharyngioma. So you put together all this thing, and you will do the diagnosis most of the time. The main differential diagnosis is a rat-leg cleft cyst. This is from Radiopedia, just to show that this can be very tricky, very big with hyperintensity 1 signal, and you need really to, in this case, it's difficult to distinguish from craniopharyngioma, but what you use is the location, the fact that there is no defined nodule in the rat-leg cleft cyst. Sometimes craniopharyngioma can be more solid, like in this case, but again, you have calcification, you have solidocystic areas, and this enhancement surrounding the cyst. You can have hydrocephalus, so don't forget to report all the findings. So look at the calcification. Most of the craniopharyngiomas, they have calcification, and this is very, very helpful for the differential diagnosis. And main differential diagnosis will be the optic pathway glioma. Another differential diagnosis is LCH, langular cell histiocytosis. You have a small nodules that show contrast and thickening sometimes of the stalk, like in this case, but again, the posterior bright spot is missing. So remember to look at the posterior bright spot, and again, in pediatric neuroradiology, very important to look at the whole picture and look at the associated finding, especially in some cases, like in this LCH, has a lot of associated findings. So don't forget the bigger picture, the famous vertebra plana, but also, so typical of LCH, but also typical location of LCH is the petrous bone, the T-bone, temporal bone, mastoids, and petrous bone. So you can see this quite aggressive process at that level. And so don't forget this. And don't forget that the location in the skull with this erosion, you can see this different involvement of the inner and outer table. They show a mixed signal, sometimes restriction, but they are not as restricting and as reactive as, for instance, the neuroblastoma. So other associated finding, skull. And finally, again, thickening of the stalk, but remember degenerative autoimmune degenerative changes in the brain, especially but not only in the cerebellar white matter. So these are all the findings that you can find in LCH. You need to remember them and you need to look for them, because sometimes can be difficult to differentiate something like that from a benign process or something that you are not sure about. But if you see other findings for LCH, the diagnosis becomes very easy. This is a 4-year-old male. This is again a suprasellar tumor. The pituitary gland is not involved. It's quite bright. What is that? Can be a craniopharyngioma, but it's very much solid. And you do a CT, you don't find calcification most of the time. It's T1 hypo-intense rather than hyper-intense, although here it's not shown. And there is this out of focus but homogeneous enhancement. And you need to be able to demonstrate that you cannot see the chiasm. It's not displaced like in craniopharyngioma, but it's part of the tumor. And this is typical of low-grade glioma, in particularly optic pathway glioma. Another example, this is all a lecture about bigger picture. Another example of the bigger picture is the fact that if you see an optic pathway glioma, you need to think of NF1. It's not all the cases, sometimes it's sporadic, but if you have NF1, you look for associated findings. Again, optic nerve tumor, UBOS, or FASI, the involvement of the hypothalamus, again, optic nerve tumor, dysplasia of the sphenoid, and don't forget moya moya. You can have moya moya disease in 3 to 10% of patients with NF1, especially when they become older, so do not forget this. Finally, do not forget this pitfall related to pilocytic astrocytoma. They can have very aggressive looking spectroscopy and areas of hyperfusion due to the vessel. This is an ASL CBF, but they will never show diffusion restriction. So trust diffusion first for the differential diagnosis. This is not a GBM. This is not a GBM. This is an optic pathway glioma. So trust the diffusion first is my top tip for differential diagnosis of most of the pediatric neurotumors. And this is another case, 3-year-old, but important is the clinical information that we have. This is a child with seizure, and also we can see that the localization is in the tuber cinereum, so the floor of the third ventricle, iso-intense to the gray matter. This is an hypothalamic hamartoma. We have pedunculate version or sessile version. What is important about that? Most of the time they are isolated. You may need to treat them with laser ablation, which requires some specific sequences. I will not go into details, but also what I suggest is just have a look to the here, because most of the time are normal, but when you see this enlarged of internal auditory canal with this corkscrew appearance, and frank hamartoma or slightly dysmorphic hypothalamus, even without seizure, this is diagnostic combination. I mean, this appearance is already diagnostic, but if you start with an hamartoma, look at the ear, you find something like that, you have done a diagnosis of X-linked deafness due to POU3F4 mutation. This is the incomplete partition type 3, virtually pathognomonic of 95% of the children with this malformation. They have this genetic abnormality. And there is a link between the hypothalamic development and the inner ear. Most of the patients with Pallister Hall syndrome may have cochlear hypoplasia. And this is again, Pallister Hall syndrome is associated with a lot of abnormality, but the most important is the hypothalamic hamartoma. But look at it here and again connect the dots. This is our GOSH protocol. We use Axel T2. Don't forget the CIS. Use diffusion and susceptibility. And remember post-contrast sequences, but also we do a coronal post-contrast flare, because we found that the flare post-contrast is very sensitive for small leptomeningeal disease. We use orbital sequences with the parasagittal as well, FATSAT post-contrast in case of a suspected retinoblastoma. And don't forget the spine, because most of these tumor metastatize. And then consider MRA in case of NF1, but also when the patient has craniopharyngioma treated with proton beam therapy. Finally, two cases. This is a large mass, not showing really restriction, maybe just a bit, but the signal is not very dark in ADC. Not much contrast, a lot of perfusion, and this intermediate T2 signal. So we called whoever reported this scan called low-grade glioma. Someone else called this as a germinoma. They did the biopsy, and this was a diffuse midline glioma, basically the supratentorial version of the DIPG. Very, very strange location, but possible. And another case that we call germinoma, with the large mass here in the third ventricle and a metastasis, what we interpreted as a metastasis along the gyrus rectum. Look at the calcification, diffusion restriction, intermediate enhancement, and signal in T2. But in the spine, then we found this nerve tumor, and also in the eye. So actually, this was an intracranial meningioma, suspected schwannomas in the spine. This is probably NF2 under investigation. Again, look at the bigger picture, but again, this is time for reflection. Sometimes no matter how good you are in the differential, no matter how much you study, you cannot get it right, but still you shall keep trying. And this is one of my best quote, the quote that I like the most from Samuel Beckett: try again, and fail better. I need to acknowledge my colleagues from Gosh, also Cesar Alves and Sotiros Business. Cesar Alves is a CHOP, Philadelphia, and Sotiros Business, UCLH in London, and Queen Square Hospital. And this is from Amalfi Coast, where I'm from, so come and visit. Thank you very much, and this is the end of the lecture. Please feel free to send me an email if you have any question.